Listen, Doctor, as Harvard's Francis D. Moore, with this brief comment, keynotes the coming hour's listening.
How do you define a giant disease? Well, I define it as a disease that is very prevalent in the population, which is very lethal and an important age group, and which is unsolved. By that definition, we are dealing with one of the giants of surgical disease here today. And we're mostly going to be talking about the primary disease.
The giant disease under discussion, breast cancer, as three distinguished surgeons join program moderator Moore in outlining some important diagnostic and therapeutic considerations in the management of primary carcinoma of the breast. On Audio Digest Surgery, Volume 17, Number 6, for the week of March 25th, 1970. Once again, Dr. Moore.
The first speaker is Dr. George P. Roseman, who is professor of surgery and head of the Department of Surgery at Temple University School of Medicine in Philadelphia. And he is going to talk with us about some new aspects of the diagnosis of breast cancer. Dr. Roseman.
The diagnosis of breast cancer has been of interest in Philadelphia, especially for quite a number of years. We have had a committee which has ceased to collect cases recently, but is still checking the data. Began around 1951, continued to about 1964, roughly, collected about 9,000 cases. And the purpose of this was to attempt to facilitate early diagnosis in our area. We started out in rather haphazard fashion, and then after a year or so, we found that there was certain data that was collectible, and from that time on, we collected this material. And so the material that I've been dealing with in recent years has not just been my material, but material out of Philadelphia, which is roughly, population-wise, the size of Connecticut. And so the material is somewhat comparable. The data throughout supports the premise that early diagnosis is the most important controllable factor in the treatment of breast cancer. We did find that during this period of time, the incidence of breast cancer picked up by the physician in relation to that picked up by the patient, at least the earliest sign, did improve somewhat. And according to our figures, we did improve diagnosis percentage-wise by several percent during the course of this study, although it's rather hard to pin this down. The point that was the most important diagnostic guide was the presence or absence of positive lymph nodes in the axilla. This applied right down the line to all types of breast cancer. It applied, for example, to Paget's disease, which I think there was more delay in Paget's disease than most other categories. And why in the world people can't diagnose Paget's disease when you've got an ulceration on the nipple is beyond me, but in many instances there were attempts made for a time to treat this with various unctions and the like, and see if it wouldn't go away because no mass was present. But this is most obvious cancer, and I think it gives us a very fine chance at early diagnosis. But this is a killer like the other cancers of the breast, and if lymph nodes are involved in Paget's disease, prognosis is extremely poor. And incidentally, in our series, the prognosis was little better than the other forms. Carcinoma in pregnancy, we feel, should be treated just like any other cancer of the breast, and an attempt should be made by the obstetrician and the gynecologist who sees the patient to make a diagnosis if there is a lump present during pregnancy. Carcinoma in the male, we found out about a few of those. Of course, the incidence is slight, but if they are treated early, the prognosis compares with carcinoma in the female. Therapy varied greatly, and I won't discuss that now. I might mention that there are several adjuncts to diagnosis that have been helpful. Incidentally, we would like to push back early diagnosis before we can palpate the mass or see the discharge or see the ulceration. And that is the purpose of the various adjunct methods that we see, and they have no other purpose. So therefore, mammography, if you happen to see a lesion in the breast which looks like carcinoma on mammography, it is an adjunct, but if you've got a mass presence, you really don't need mammography at all, and biopsy is the only answer. Thermography has improved our diagnostic incidence, especially when combined with mammography in our area. And of course, zero radiography is now experimental, and we expect great things from that. One thing that's been most helpful to us is to differentiate between the cystic and the solid tumor. The cystic tumor is rarely malignant. We've been able to collect about a half a dozen during my sojourn at Temple over a period of about 30 years, and they're rather hard to find, whereas solid tumors are very commonly cancer, especially as a person gets older. So we think it's extremely important to differentiate between the cystic and the solid tumor. We treat our cysts by needle aspiration. It's purely for the purpose of differentiating between the cystic and the solid tumor. This is not a method of obtaining a specimen. A very small needle is used, 20 gauge.
There are a couple of endocrine questions here for Dr. Rosemond. One is, what about the stage of the menstrual cycle in relation to aspirating cysts?
Well, of course, we prefer to examine any woman with a mass in the breast shortly after menstruation, but we don't necessarily go by that. As a matter of fact, sometimes the mass has been there through several menstrual cycles, and of course, therefore, we might as well go to work when we see the patient. We don't care to delay.
And secondly, what in your experience is the effect of the use of birth control pills on heavy cystic masses in the breast?
As far as the pill is concerned, I don't know that it's had any particular effect. Sometimes it makes cysts appear and sometimes it makes them disappear. As far as I'm concerned, it's variable, and the very small estrogenic substance used for the pill ordinarily has very little effect. Of course, sometimes, as you know, it does have an effect, and it even produces bleeding from the nipple, and sometimes it produces mastodynia of one sort or another. So it's a variable effect, and we don't take it into account.
What do you do with a patient with painful breasts and cystic lumps and things who is on the pill?
Well, our inclination, if the patient is on the pill, is to stop the pill for a time. If they have painful cystic lumps, which were not there before the pill was used.
I think that's a good point. We've had a number of patients who have change in breast symptoms and much more noticeable lumpy breasts that we have taken them off the pill and put them on a uterine coil merely because of breast symptomatology, which was worrisome to them. Our next speaker is Dr. George Kreil, Jr., Senior Surgeon of the Cleveland Clinic, Cleveland, Ohio. And he is going to speak on some of his current thoughts on the management of the primary disease. Dr. Kreil.
As you know, the treatment of breast cancer in this country is still in a phase of controversy. Operative stage 1 breast cancer is not the same as clinical stage 1, because if you explore the axilla after you have mobilized the breast and broken into the axillary space, just as you explore the abdominal cavity, if you do that at the time of operation, your accuracy of interpretation of whether or not lymph nodes are affected is approximately 3 times as great as it is in clinical. As you know, in clinical, you can't bet, no matter how good you are, more than about 70% accuracy. You get only approximately a 10% error on whether or not nodes are involved when one examines at the time of operation and after one is experienced in looking for the beating of the lymphatics and the consistency of the nodes rather than the size, which denotes involvement by tumor. So then, if we think that the disease is in stage 2 at the time of operation, a commitment which we make only when we have explored the axilla, we of course don't have any notion that the disease goes away or that you should leave the axilla intact. Nor does it make any difference how you treat the axilla from the standpoint of the patient's survival, whether you do it by ultra-radical, by modified radical mastectomy, or by simple mastectomy and irradiation. We have not in this country paid enough attention to the very excellent randomized studies that have been done abroad, for example, by Haybiddle and his associates in England, in which they randomized between modified radical and radical mastectomy, conventional radical type. Modified radical, I will stop here to define as being an axillary dissection without removal of the muscles or a division of the muscles or anything else. And randomized between those two, there was of course no difference in survival rate, nor has there been any difference in survival rate in the randomized studies of Peterson and his associates, whether patients were given postoperative irradiation therapy after radical mastectomy, provided the nodes were involved. If, however, the nodes were not involved, there was a small difference in favor of not irradiating. The third famous study, of course, is that of Kay and Johansson's, in which they randomized between ultra-radical and simple mastectomy with irradiation and found that up to 10 years there is no difference in the survival rate between these two methods. So we will admit that something has to be done, but it's dealer's choice, and the main thing is to do the operation that will give the maximum control with a minimum morbidity when the nodes are involved. In my books, when the node involvement is minimal or medium, that's a modified radical mastectomy. When it's maximum, and I go right along with Higginson and his group, when apical nodes are involved or there's extensive axillary involvement, then I think it's better simply to do a simple mastectomy and irradiate the axilla, like McWhirter. Now, we'll go on to the thing that I'm really interested in, and that is stage 1 breast cancer, because here there have been no randomized studies to indicate whether there is any advantage from the standpoint of survival in not doing an operation which removes the regional nodes or irradiating the regional nodes. Because from the standpoint of function, irradiating nodes and removing them are identical. Only takes a very small amount of irradiation to abolish the immunologic function of lymph nodes. My colleagues and myself were operating upon patients, my colleagues believing more in removing nodes at that time, and I believing less in it. So we had patients for comparison with very similar material. And we found that there were a group of cases, of course, who had occult nodal metastases. These are the 10% where we didn't think nodes are involved, but nodal metastases indeed did occur. And if they had an axillary dissection at the time of the original operation, a radical mastectomy or its equivalent, we found that in these, the pathologist, of course, would find the tumor present. In the ones who had only a simple mastectomy, the patients were kept under observation, and in approximately the same number of cases, an axillary dissection then was done at a later date, if and when the nodes appeared. So both of them had occult cancer in the axilla, both of them subsequently had proven cancer in the axilla, and there was no difference in these patients whether one did the immediate axillary dissection with a 68% 5-year survival rate, or whether one deferred the axillary dissection until such a time, usually an average of 2 years, until the nodes were palpable and then removed them. Little tendency to metastasize from node to node or systemically. Now, what happens then in true stage 1 cancer of the breast? These are the ones who, if they had a radical operation, the pathologist found no nodes involved. If they had a simple operation, never during the 5 years or more course of follow-up, and we have 100% follow-up on these, was there any tumor that developed? None of them, of course, had any radiation. And the size of the two groups of tumors was the same, because we eliminated all very small tumors because there was some selection in favor of small tumors to be treated by simple operations. Age was the same. They were operated on during the same period of years. So we think that the two series are comparable. Yet there is a quite startling difference between the survival rate of two groups. 82% when there was a simple operation done without any radiation, and when we removed the nodes, it fell off to 65%. Now, our overall 5-year survival rate has been satisfactory. And again, here we have adequate experience since 1957 with some 390 patients treated primarily for breast cancer at the Cleveland Clinic. The crude survival of all patients in all stages of the disease, whether they were referred for radiation, for endocrine therapy, major ablations of endocrine nodes, or what? 58%, which is a good high 5-year survival rate for crude survival. Operable 1 and 2, the 5-year survival rate was 71%, and again, we have a 100% 5-year follow-up on these. There were only 8 that we considered inoperable because they were 95 years old or something of the kind, or had other cancers that they were dying of, or other diseases. To show you that we were not selecting very heavily, the stage 3 and 4s did very poorly. Only 13% of those which weren't deemed to be in stage 1 and 2 survived for 5 years, and our local recurrence rate was remarkably low, 5%. Most recurrence rates running anywhere between 8 and 12, 15%, most reported ones. Now, I think we can explain the local recurrence rate on the basis of some of the things we do in the course of a radical mastectomy. We are operating at a time when the lymphatics are filled with cancer cells, and what we're doing when we cut a thin skin flap is to trap those cancer cells in the skin flap and damage the skin flap's blood supply and lymphatic drainage, with the result that we cause tissue damage. It makes it look more and more as though we should cut very thick skin flaps and not skin graft, because tissue damage damage. Without the cells being able to get out of that, we trap them and we promote their growth by the stasis which we produce. And finally, I would just like to summarize experience of the first years of this study, in which my colleagues were doing mainly the radical operations and in which I was doing mainly the simple operations. We had to discontinue the study because my colleagues, seeing the results, were unwilling to continue it any longer. But during those 3 years, which have now been followed out to 10 years, we have had a distinct and growing advantage of the simple operations over the radical.
We're going to go on by having Dr. David Habeff, who is professor of surgery at Columbia College of Physicians and Surgeons, present his views, and then we can have a general discussion.
We must deal with the cold facts of life, which relate to survival or cure rate statistics in relation to what kind of treatment we apply. In this connection, 5-year survival statistics for cancer of the breast are interesting, but 10-year survivals or cure rates are much more meaningful. I'm not in a position of knowledge or ability to comment on Dr. Kryle's studies, but I would like to comment later on some of his figures. To begin with, I'd like to tell you that at Presbyterian Hospital, there has been an interest over the past 18 years with the peripheral lymphatic lymph node filter and its possible implication in treatment and survival. By this we mean the internal mammary nodes and the apex of axilla nodes. We've been concerned with them to the point of doing a little more than 1,000 internal mammary node biopsies and some 346 apex of axilla biopsies. First, the axillary and internal mammary lymphatic routes. The axilla is a very large effective filter which contains approximately 30 to 80 lymph nodes, whereas what we consider as a secondary route is a small and ineffective filter. There are usually 1 to 3 lymph nodes per interspace, and they're predominantly placed in the first, second, and third interspace. And so our biopsies have encompassed these 3 spaces. The nodes lie rather close to the sternum and sometimes as far as 3 centimeters out from the lateral sternal edge. Now, if one correlates the site of the tumor in relation to the frequency of the internal mammary node metastases, far and away they come from the central zone, but this can be misleading because if the large bulky tumors in these other zones encroach, they're counted as this central zone. If one correlates the size of the tumor as it enlarges or is larger, the incidence of internal mammary metastasis rises progressively, so that of 1,007 patients, 32.5% had internal mammary node metastases. If one looks at an attempt to biopsy or dissect the internal mammary nodes in conjunction with a radical mastectomy or perhaps a modified radical, as Handley has done, the percentage of internal mammary metastases in Handley's series is 4.2%, where the nodes were involved, internal mammary nodes only, combined with internal mammary and axillary nodes 17.5, so a total of 21.5% in this stage A and B on the Columbia Clinical Classification. And when the axillary nodes are not involved, there is a small percentage of internal mammary node involvement as proven by biopsy. When the axillary nodes are involved, of course, the incidence of internal mammary node metastasis increases, suggesting that this is the secondary route or alternate filter for primary carcinoma of the breast. Clinical findings in the axilla correlated with the incidence of internal mammary metastases. And where the nodes are not palpable, there is an incidence of almost 20%. And I think all of us readily admit that, and as touched on by Dr. Kreil, there is this 30% error in palpating the axilla. If the nodes are less than an inch in diameter, the incidence of metastasis increases, and of course when they're 2.5 centimeters or more in diameter or fixed, the incidence of internal mammary metastasis is 50%. Now, as far as the apex of axilla biopsy, which was performed in some 346 patients, we take that group of nodes which lie medial to the anterior thoracic vessels, just lateral and inferior to the subclavius muscle, inferior to the axillary vein. We don't get into the thoracoacromial or anterior thoracic vessels. If the correlation again is made with the site of the primary, there doesn't seem to be too much difference, except that the lateral sectors, which drain primarily to the axilla early, have the highest incidence. And the medial sector, as one would expect, has the lower incidence. Correlating the size of the tumor, there is variation. The under 3 centimeters, 32%, but 3 to 5, 16.8, etc. But a total of 25% of the 346 patients had a positive apex biopsy. It should be pointed out that these biopsies were performed in patients where it was suspected that the apex might be positive, either because of the number of nodes in the axilla or their size. Correlating again the apex biopsy with the no nodes involved or less than 2.5 or 2.5 or more, the incidence of apex biopsy goes up rather sharply. That is, the apex node being positive. And if one correlates the apex biopsy with the Columbia clinical classification, even in stage A and B, there is almost a 25% incidence of positive apex. I will speak as one who has done modified radical mastectomies that it's not always uniformly possible to remove the apex, even though one strives very hard to do so. In looking at Dr. Kreil's data and in trying to analyze it, I think that he has come forth with a multiplicity of treatment methods which he's lumping into a simple category like simple mastectomy. And so I'm quoting from his own words that most of the patients were treated by simple mastectomy. Now, in selected cases with small and peripheral lesions, a wide quadrant excision or hemimastectomy was done. In other words, 13% of the patients did not have a simple mastectomy. Occasionally, 1 or 2 of the low axillary nodes were removed, and I'm not sure whether this is by accident or design because they were involved or thought to be involved at the time of operation. Cobalt therapy was given to this clinical stage 1 simple mastectomy in 25% of the patients. So we're now beyond the simple mastectomy group. Subsequently, if the nodes became involved, they were removed, so that this was an extension of the simple mastectomy, but still these patients are in the simple mastectomy series. And finally, in this type of series, in this group patients, several of them that had extensive involvement in the nodes, the radiation therapy was added, cobalt. Now, we go on to clinical stage 2, and when the operable node involvement was diagnosed preoperatively and found to be extensive, the patient had simple mastectomy and cobalt. And when the involvement was minimal, sometimes a modified radical was performed in clinical stage 2. Now, here is a bothersome thing. In the clinical stage 1 patients, nearly 3/4 were modified radicals. Now, the quotation marks around radical mastectomy subsequently disappear, and the axillary dissection was as complete as possible in the radical mastectomy series clinical stage 1. The radiation therapy was given to slightly less than 1/2 of the patients. This is the radical mastectomy series clinical stage 1. Clinical stage 2, slightly more than half of the radical quotation operations were modified with preservation of the muscles. The rest were conventional radical mastectomies. Now, what's worrisome to me is that in this simple mastectomy group, we have a number of types of patients which we've reduced to this word simple. And I submit that it's not that simple. I think that Dr. Kreil should take out of that group or break it down into a number of things. And when he's talking about radical mastectomy, he's equating modified radical mastectomy, where the muscles are preserved, with true radical mastectomy. Now, in personal series of Dr. Higginson's, at the 10-year survival time, or the 10-year time for survival, it drops from 90% at 5 years to 70% at 10 years, and stage B, 60% at 5 years to 40% at 10 years. A series of cases performed by Dr. Kennedy in Detroit and compiled by Elmer Miller, in which simple mastectomies, true simple mastectomies, were performed, followed by less than 1,000 R, or rads. So in effect, simple mastectomy, and at the 10-year level, Columbia stage A is 39% instead of 70% for the radical mastectomies, and B is 28%, albeit a very small number, instead of 40%.
The conclusion of the presentation by Dr. Habuff signals the end of this side of Your Real Doctor. On side B, Dr. Moore questions Drs. Kreil, Habuff, and Rosemond on some points raised by their discussions. To hear this, just flip over the cassette, or 2 reels, on your tape recorder. A program on the management of primary carcinoma of the breast continues now on this, side B of Audio Digest Surgery, Volume 17, Number 6. And here once again, our program moderator, Dr. Francis D. Moore.
We do have a number of questions, and I think we should start with the diagnosis of the primary disease before we go on to the treatment modalities. Maybe we should start with one ground rules question, and that is, I would like to ask Dr. Kreil to define his stage 1 and 2, and Dr. Habuff to define Higginson's stage A and B.
Ours is a Manchester staging, and it is just whether or not one can feel nodes in the axilla, which makes it a 2. If you can't feel nodes in the axilla, it is a 1. Of course, the same things if there are multiple satellites all over the chest and fixation of everything, that puts it into a 3.
But you started out with a little statement about operative staging versus...
Oh, well, but this is a more recent development. This is all clinical staging.
Your statistics were all clinical.
Statistics are clinical staging because...
And then just exactly what do you mean by operative staging? Do you mean based on the pathological findings?
No, I mean exactly what I said when I was standing there a couple of minutes ago.
Carry on.
I mean that at the time of operation, you make up your mind whether you do or do not think that the nodes are involved.
So that your operative staging means simply clinical staging done at the time of the operation, is that correct?
And it's about 2 or 3 times as accurate.
You mean because the patient's anesthetized?
Because you can feel them. You can't feel the nodes in a thick person, and the consistency of them you can't
But your operative staging is not to be confused with pathological staging.
No, of course not.
All right. Dr. Habuff, how do you define A and B in the Cushman-Higginson category?
The stage A is where there are no nodes palpable in the axilla which are suggestive of metastases. Now, that relates predominantly to consistency because obviously many women have palpable lymph nodes in the axilla which are soft. Stage B relates to a clinically involved node which is less than 2.5 centimeters in diameter.
All right, well, let's go back to Dr. Roseman then, and we have a lot of questions for him, but let's ask one that seems to be in many people's minds. What do you do with large, multiple, recurrent cysts, unilateral or bilateral?
Well, that's ordinarily not any particular problem because most of these cysts are fluctuant. If you have a fluctuant cyst that is not tense, it's not even worth needle aspiration. I have never seen a carcinoma in an obviously fluctuant cyst. So we can eliminate most of the cysts that you see on that basis. The ones that we aspirate are the ones that we're unable to differentiate clearly between a solid and a cystic lesion. And we do our aspiration primarily to make this differentiation. And secondly, in the case of the cyst, to cure it without surgery. And we think surgery under those circumstances is unnecessary because these cysts generally go away without further treatment.
But in the multiple bilateral cyst, do you just leave the patient as she is with her painful breasts?
Well, it depends on how painful. We're talking about a different thing there. The reason we are doing this primarily is to make the diagnosis of cancer or to rule it out. And if you've got a patient with multiple cysts throughout the breast, it might be that there's several of them we'll aspirate with a needle, as a matter of fact. What do you do when you operate? How do you tell which one to take out? Do you do simple mastectomy, or do you do random biopsy, or what do you do? Or do you do haphazard biopsy, which I think many of these biopsies are? We'd like to know what we're aiming at when we biopsy. If we cannot get rid of a lesion by aspiration, then we think if we can find the lesion and know exactly where to biopsy, that we should biopsy. And so if you've got multiple cysts, maybe the cysts are tiny little things, maybe they're in clusters and we're unable to eliminate them by needle, we may resort to biopsy. In fact, we do, under those circumstances, resort to biopsy. So if your method is not positive, if you can't tell definitely that the mass is gone and that it does not immediately recur, then we go right ahead and resort to biopsy.
Here's another question.
Excised.
If you're worried about the cosmetic aspects of breast biopsy, why do you use those disfiguring radial incisions instead of circumareal or submammary incisions, which are so preferable cosmetically speaking?
Well, we don't always use the radial incision. As a matter of fact, what we try to do is to use as cosmetic an incision as is possible to fit the circumstances. Now, if we think we're going to do a radical and we've got a lesion high in the upper outer quadrant of the breast, and therefore we think we cannot satisfactorily use a transverse incision, which we prefer for radical, as a matter of fact, then we might use a radial biopsy. We want to be able to get the lesion out.
I think the radial wagon spoke incision for breast biopsy is an abomination, and that using a submammary incision it's possible to reflect the whole breast, turn it inside out, and do as much biopsying or berry picking as you wish and return a breast which is cosmetically virtually perfect, and the same thing's true of a circumareal incision. Now, before we leave the question of aspiration, Dr. Kreil, would you like to comment on needle aspiration of cysts? How do you bring that to bear in your approach to women?
We do this exactly the same thing, except we use no Novocaine. I think the Novocaine hurts more than the 20-gauge needle.
And if the cyst goes away, you leave the patient alone. If there are multiple cysts, will you sometimes aspirate in multiple sites around the breast?
Oh, yes, sure.
Do you ever do a pap smear on this fluid?
We used to, but we never find anything.
Here's a question. How would you handle a class 5 extremely suspicious pap smear without a mass or mammographic localization when the cyst completely disappeared after aspiration?
Well, I don't know what a 5 is.
That's extremely suspicious of cancer.
Well, anything that's suspicious at all, I would want to excise.
In other words, you would pay attention to that pap smear.
Sure, but...
Then why don't you do it on all the cases?
For the simple reason that I've probably done 3,000 of them and never found one yet unless there was something funny looking about the fluid. When there's something funny looking about the fluid, I do.
You mean you've done 3,000 pap smears or 3,000 breast aspirations?
Well, probably done at least 1,000 pap smears because we did them regularly the first few years.
Did you give them up because you weren't finding
anything? Never found a thing unless there was something funny looking in the fluid.
Dr. Habif, how do you
deal with this particular aspect of aspiration and pap smears?
I'm pleased to report that I find myself in 100% agreement with Dr. Kreil.
What do you do?
We have employed aspiration of cysts for more than 30 years at our hospital. We've made the observation that cysts seem to appear most commonly premenstrually and seem to resolve spontaneously shortly after the menstrual period. However, in that instance where there are single or multiple cysts which do not disappear completely by aspiration, we operate upon such patient. It's been our observation that the multiple cyst patient is less frequently operated upon than the single cyst patient. We believe that the incidence of gross cystic disease in the adult female population having regular menstrual periods is of the order of 20%. And we feel that the incidence of cancer in the cyst, in my own experience, 2 patients doing this for 30 years, and the incidence of cancer near a cyst is so small that we can justify aspirating cysts to keep these patients from operation and out of the hospital.
All right, I think we might move on along to the next point now, and this has to do with other methods of early diagnosis, and there's several questions here that relate to mammography, and they all take about the same form. What do you do with a patient who has a positive mammogram and no palpable mass in that breast? Dr. Roseman.
Well, it depends somewhat on how positive the mammogram is.
Let's say it's good and positive, just to give you something to tie into.
All right, if it's good and positive, then we biopsy that area, and we make sure that we have taken out the area indicated in the mammogram.
Can you tell us of some pathology that you have found revealed by this sequence?
Well, we found carcinoma. That's what we were looking for.
And have you found carcinoma fairly often under those situations?
Well, you said it was quite positive. If you have the fine stipple calcifications in a localized area, almost invariably it's been carcinoma, even though we can palpate absolutely nothing in the area. I think that is the most positive indication. That's the reason I asked you how positive it was, because there are certain findings that might possibly indicate cancer that can oftentimes be easily explained on other bases. For example, infection will give you edema of skin. When you have an obvious infection, we don't operate on furuncles with the idea of finding cancer cells. We also know that in a certain number of people, it's rather difficult to differentiate the multiple cystic affairs in breast, many shadows, opaque shadows in breast, from true carcinoma. And so if a radiologist tells us that he can't tell whether there is cancer in the breast or not, we would almost prefer that he not give us this report, because we know that already. In about half the women who are premenopausal, it is most difficult to tell whether there might be a small carcinoma in the breast unless this stipple calcification in a localized site is present, and that is very positive in our experience.
Do you take a mammogram on both breasts of all patients in whom you aspirate cysts?
We prefer to, yes.
So that your routine would be the aspiration and the mammogram?
Mammogram, and we add thermogram in our institution, but we're not quite sure about the value of thermogram at this moment. We think that thermography plus mammography gives you some adjunct help in making the diagnosis.
Well, I think one way for a moderator to shorten his life is to try to synthesize opinion, and yet that is maybe a useful thing where so many of us are concerned with the disease. And it seems to me it's the consensus of the panel that to approach patients with cysts in the breast by aspiration is a reasonable course, even multiple aspirations, that Papa-Nicolau smears don't add much. I would only add to that that if they are negative, they give you a false sense of security. But any patient who's come to you bothered enough by her breast to have a cyst aspirated, it seems to me, should have a mammogram done on both sides, and that's one of the places where the X-ray is really very useful. Dr. Kreil.
I'd like to say you didn't properly interpret the panels, Franny. We do not believe that mammograms are of much value in the presence of cystic disease. At least 2 of us don't.
Correct.
Well, then it's about even, because there's another 2 of us that do. So there, I told you.
I don't think it has anything to do with making the diagnosis of the cyst, but we have on occasion just thought we had cystic disease and picked up a carcinoma.
Right.
I think these breasts that have cystic disease, you're lulled into a sense of security. You think you've got a cystic disease, so therefore that explains everything. Well, it doesn't necessarily explain everything. In Boston, I think somebody that you might have heard of several years ago even thought the incidence was several times higher in those patients with cystic disease. We're not sure about that because we're not quite sure just how you make the diagnosis of cystic disease. We think most women have cystic disease at some time or another.
All right, well, let's move along to our next point. And Dr. Kreil, I think, should have the privilege of a rebuttal to Dr. Habiff's analysis of his data.
I don't have to rebut anything at all because I was highly flattered by Dr. Habiff to take so much time to put over my points. The only thing is that I wish next time, for the teaching value of it, he would let me do it to fill in the context, because it's notoriously ineffective to teach with phrases out of context. Now, the second thing is, what I showed at the end of survival represented a defined group of 1955 through 1957, in which my colleagues are mainly doing the more radical procedures and I was doing simple. Now, I want to point out that during this period, the reason we did so many different procedures is because we literally cannot do a randomized study and commit ourselves to this type of a thing. There are too many exceptions to the rule to have it spread through the whole spectrum of breast cancer when you have personal feelings about what's better or worse. So during this period, we just merely divided, and we called radicals anything which made an attempt to remove lymph nodes, and we called simples everything that didn't make an attempt to remove lymph nodes. And as everybody knows, sometimes even when you don't attempt to, a lymph node comes to the breast.
How about the simples where the lymph nodes removed later?
But that, of course, is exactly the same way any simple operation is, whether it's cancer of the lip or melanoma. Of course you do it later. I don't say that you don't have to pick up the
But you classified those in with the simples.
Of course they're simples.
Yeah.
Yeah, because the initial operation was a simple disease, and because the immunologic function of the nodes was preserved. And so that's the only thing about the delayed operation. It's no different than any other delayed operation. There's nothing mysterious about this. And if you read what I've said in relationship to what I was trying to prove, namely that removing of nodes is a bad thing when they're not involved, and keeping them is a good thing when they're not involved, and that it doesn't do any harm to wait until they do become involved, if they're going to remove them. That's all I've said. Now, the postoperative radiation was given largely by my colleagues and applied only to the first series, the up to 1957. Since that, we practically did no radiation in our stage 1s. And I think I've explained about everything there, except one other thing, that I think it's an absolute waste of time to compare a series from one institution and another institution, because they are not the same material going into it. It's not the same way of standardizing the stages and everything else. All you can do is to make a comparison within your own institution. And I think we should pay more attention to the randomized ones that have come out of England and Scandinavia.
Of course, they're multi-institutional.
The ones,
Dr. Kreil, I'll give you something to rebut. And that is that at the beginning of your talk, you said that you were now doing radicals in your stage 2s. And
you see, Franny, you don't listen carefully. I said we do modified radicals in those cases in which we think the lymph nodes are involved at the time of operation, and in which we think that the involvement is only minimal or moderate. But if we think there are 8 or 10 nodes involved, or the apex is involved, then we'll do a simple operation with irradiation, because we agree with Higginson that these are inoperable when the apex is involved.
Well, then, to make another hazardous venture into consensus politics, I take it that we are all agreed that in patients where there is some evidence of lymph node involvement, especially in the lower axilla, not extensive, we are all starting with a radical or modified radical mastectomy. Is that correct?
Oh, that would apply to me, yes. Except I would never do the radical under any circumstance.
But you would
do the modified radical.
You do the modified radical. How about you, David?
The answer to that is no, but I would like to comment on one aspect of what has just been discussed. I think that under certain circumstances, where the disease is moderately extensive in the axilla, A modified radical mastectomy violates one of the first principles of cancer surgery, namely, trying to get around it with a reasonable margin of uninvolved tissue. Now, I don't know, but I suspect that perhaps one of the reasons Dr. Kreil's radical mastectomy series survival is not as good as the simple mastectomy is that this factor may have come into play, namely that the patient might have been made worse by the modified radical than they would have been if they had had a standard radical.
Supposing that they all got local recurrences and died from them, we only had 5% local recurrences, and that isn't as much as the spread between these two groups.
Here's another question. Dr. Kreil, how come your 5-year survival rates for radical operation is so much lower than other comparable studies?
I'm just as concerned as the one who asked that question is about why the radical is as low as it is, because if it had been 5% under, I would have believed it. But the series is small, and the 13% is too much. 17% actually it is. It's too much difference. That is definitely too low. The reason all the figures are low, as I said, was because we took only tumors that were 2 centimeters or more in diameter, I think what the cutoff point was, and that throws out all your most favorable ones. So the survival rate is low all the way through. The reason we had to do that is to get comparable groups in size. Otherwise, there was selection for simple operations according to size.
Dr. Habef?
I would beg of Dr. Kreil that he separate within these two broad groups. For example, in the simple mastectomy, he put down clear-cut simple mastectomies. And in the radical mastectomy, he separate modified radical from radical so that we who are trying to find out what the proper form of treatment is will be able to distinguish.
I think you have to accept Haybiddle's studies. He did a randomized study on radical versus modified radical and had to discontinue it for what he called humanitarian reasons, because the morbidity was higher with the radical and the mortality a little bit higher too. And so he had to discontinue it after about 7 years.
I'll accept any kind of humanitarian reason you want. But
all right, but let me tell you why we can't do it, and that is because there's only been one radical mastectomy done at the Cleveland Clinic since 1957 by my colleagues and myself and everybody else. They're all modified now.
I thought that 25% of them in that group were standard.
That was the first series, you see.
Well, Dr. Kreil, I'm not sure that
we've got two different series, one up until 1957, the other.
I would like to ask you a question: that how can you be telling us about occult or pathologic stage 2s if, as a matter of fact, you don't take out the nodes unless they are clinically positive?
But you see, Franny, I'll go through it all over again. You're in the axilla. I'll try to make it visual for you.
Yeah.
You don't feel anything, but you feel like you do about.
You mean you open the axilla?
You open the axilla. You don't feel anything you would think is cancer. Yes.
Yeah.
Break into the axillary space. Roll it between your fingers. You feel nothing in there that feels like cancer. You're going to be wrong 10% of the time, and there will be cancer there. And if you are one who likes to do prophylactic operations, then you will take out the nodes and send them to the pathologist, and he will find it. That's one of our groups. The other group is myself, who, if I feel nothing, do nothing, and then sometime, if there's cancer there, within the next 10 years, it's going to appear. And then you take it out.
Well, I always knew there was enough of Dr. Kreil to make a group. I'm glad to hear it. Now, let's move on to something that may possibly be less contentious. Dr. Habef, several people have asked the question, do you and Dr. Hagenson still do the so-called triple biopsy? And if so, would you like to describe your technique of intercostal biopsy, internal mammary, very briefly?
Well, the internal mammary biopsy has been abandoned. Now, knowing that, would you like me to describe the technique?
But you might just tell us, was it abandoned because of those figures, that its involvement can pretty well be predicted from other indices?
Well, that and the decision that a number of patients who were not being biopsied had internal mammary metastases, and the disease was being mixed so that there was subsequent parasternal or other recurrence or appearance of disease. And so the decision was made that in clinical stage A and B, All patients would receive radiation therapy to the internal mammary chain from the lower portion of the clavicle to the lower portion of the fourth costal cartilage, except for a tumor of less than 3 centimeters in the upper outer sector, clinical stage A, not pathological. That patient would not have radiation therapy. Now, in the instance where it was suspected that the disease might be in the axilla because of the large size of the clinically involved single node or multiple nodes in a group or chain, the apex would be biopsied. If the apex nodes, some 3 to 7, were positive, the patient received radiation therapy only, unless the breasts were very large. And then subsequently, if the tumor in the breast persisted or regrew, the patient would have a simple mastectomy. Now, finally, in the group that had radical mastectomy for stage A and B, if the axilla contained fewer than 8 positive nodes, the radiation therapy was delivered 5,000 rads to the internal mammary chain only. If 8 or more nodes were involved in the axilla, radiation therapy was given to the supraclavicular, infraclavicular, and axillary regions in addition to the internal mammary area.
Thank you, panel. Before concluding this program, let's listen as Jefferson Medical College's Thaddeus L. Montgomery provides some diagnostic pearls about what to do when finding a lump in the breast.
Well, first, in today's management, it is probably wise to send most of these patients for a mammogram and thermogram. This does several things. It helps to perhaps confirm the tentative clinical diagnosis. It also gives a survey of the remaining breast tissue and the opposite breast, and gives a foundation upon which future mammograms may be taken for comparison. Then it is probably wise to recheck this lesion after the next menstrual period, assuming that the patient is still a menstruating patient. And if not, within 2 to 3 weeks at the outside. When should a biopsy be done? Well, if the lesion persists on re-examination and the mammogram is positive, then certainly a biopsy should be done. If the lesion persists and the mammogram is negative, a biopsy should be done. If the lesion is ill-defined and the mammogram is positive, and the radiologist can carefully point out in one direction or another where a minute lesion exists in the breast, then it is probably imperative to do a biopsy. So that the mammogram is an adjunct to diagnosis, but not a replacement of clinical diagnosis from the clinician's standpoint. What type of biopsy should be done? Well, ordinarily, in the case of large lesions, we simply do an incisional biopsy so as not to disturb the primary lesion any more than is necessary. Incise into the lesion, open it, and if it is obviously carcinoma, take a sliver of tissue for examination, for confirming by frozen section or paraffin section, and close the lesion. If the lesion is small, it is better to do an excisional biopsy and submit the entire lesion for microscopic study. Should this be done independently from, or should it precede directly, a complete mastectomy? Well, I think this depends a great deal on the judgment of the operator and the conditions that are present. Suffice to say, however, there's a general feeling today that a delay of a few days between biopsy and definitive therapy does not compromise the end result. And therefore, a carefully performed biopsy and a carefully closed incision, consulting not only frozen section but paraffin section, making a secure diagnosis, and then taking some time to decide upon treatment, because treatment today in carcinoma of the breast is not just total mastectomy. This gives an opportunity for the obstetrician, the gynecologist, the general surgeon, if he is to do the definitive surgery, to get together and decide what is the best measure in the treatment.
Thank you, Dr. Montgomery. And this doctor ends this edition of Audio Digest Surgery, produced and copyrighted by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Your next issue will be mailed to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over a 52-week calendar. Thank you, Doctor, for listening.